I'm just going to make it, I will have a brief presentation about how can we start a mitral program, specifically starting with a clip and, eventually advance to more of tricuspid and TAMVR programs. I know for some of you guys, this might be like very simple and all of this, but I think for some of the programs that they don't have a mitral, I think it will be helpful. So these are my disclosures. And to start with, till now, believe it or not, surgical mitral valve repair or replacement is the mainstream and the standard therapy for severe mitral valve regurgitation. It does have evidence to improve quality of life, prognosis, and survival. However, the problem with a big percentage of those patients, they are high-risk patients, they are elderly patients, MAC patients. So those patients, the surgical repair and replacement is really at high risk, and that's why sometimes they don't have a surgical option. Mitral clip is basically a translation of the surgical Alfieri stitch repair technique. It showed that it will achieve a durable reduction in mitral regurgitation, decrease in LV function, in diastolic volume, fewer hospitalization, and improved functional status, with also a quick recovery. I will talk a little bit about the CMS requirements, which is divided into the care team requirements, care management requirements, procedure requirements, hospital requirements, and of course, the importance that it's very important to participate in the national registry for the mitral clip and TIR. So FDA approved indications for mitral clips, the symptomatic degenerative mitral regurgitation, and symptomatic moderate to severe or severe functional MR. For the functional MR, it has to be after maximized guideline-directed medical therapy and cardiac resynchronization. So for the degenerative MR, if this will achieve percutaneous reduction of significant MR more than 3 due to primary abnormality of the mitral apparatus, which is usually the degenerative part, in patients who has been determined to be at prohibitive risk for mitral valve surgery by the heart team. And the heart team approach for this include a cardiac surgeon who is experienced in mitral valve surgery and a cardiologist who is experienced in mitral valve disease. Also, those patients should not have comorbidities that will preclude from the expected benefit from reduction of mitral regurgitation. So if that's not going to help, then those patients also are not indicated for that. For functional MR, as we said, it's symptomatic moderate to severe MR in conjunction with maximally tolerated guideline-directed medical therapy. Patients who have symptoms persist and MR severity persists despite maximum TMT as determined by the multidisciplinary heart team experienced in evaluation and treatment of heart failure and mitral valve disease. Patients who have existing comorbidities which will preclude the expected benefit from the TIR, or patients who have untreated severe aortic valve stenosis, those categories they are not covered and they don't have the indication for the TIR. For multidisciplinary team requirements, you need a cardiac surgeon who's board certified with more than 20 mitral valve surgery per year or more than 40 over 2 years. 50 of those has to be mitral valve repair. For the interventional cardiologist, at least 50 carrier structural heart procedures or more than 30 left-sided structural heart procedures. And also have to participate in at least 20 carrier transseptal intervention. At least 10 of those, the cardiologist has to be the primary or co-primary operator. For the interventional echocardiographer, which it can be a cardiologist or anesthesiologist, they have to have at least 10 transseptal guided procedures and more than 30 structural heart procedures. Of course, they have to be board eligible or certified. For the heart failure cardiologist, they have to have experience in treating patients with advanced heart failure, and this is only required for the functional MR. Of course, other providers, APPs, nurses, research personnel, and data abstractors. So for the care management, all those MR patients, evaluation for suitability for surgical mitral valve repair or TEER or CLEB or palliative therapy should be documented and should be available for the team before proceeding. For functional MR, the heart-failure cardiologist must document that the patient has persistent symptoms despite the maximally tolerated TMT and cardiac resynchronization. However, the exception for this, if the patient is being taken care of a cardiologist who is experienced in patients with advanced heart failure, then the heart failure cardiologist can only um, um, review the chart and the images and just document in the note. For the interventional cardiologist and the heart failure cardiologist, they must independently evaluate the patient and the medical record and have face-to-face examination. For degenerative MR, the interventional cardiologist and the CT surgeon must independently evaluate the patient and have the medical record and the images and the face-to-face examination. For procedure requirements, either the interventional cardiologist or the CT surgeon can or must perform the CLEB the procedure. The interventional echocardiographer from the heart team must perform the TE, and also if that's is an anesthesiologist, he cannot do both. He cannot administer anesthesia and do the TE at the same time. Both the interventional cardiologist and the CT surgeon may participate on the intraoperative technical aspect of the CLEB, and all physicians who participate in the procedure must have the device-specific training as required by the manufacturer. For the hospital requirements, the hospital must have on-site heart valve surgery and interventional cardiology program, and they must have a post-procedure ICU facility that with experienced personnel and nurses in management of patients who undergone open heart surgery. The hospital volume requirement, which it's a must to start a program and you must maintain at least 20 mitral valve procedures for severe MR per year, or 40 over the last 2 years, and at least 10 of those must be a repair. More than 2 cardiac surgeons who have privileged and experience in valvular surgery, more than 1 physician with interventional cardiology privileges, and more than 300 percutaneous coronary intervention per year. It's very important and vital to be part of the national registry participation, and the criteria for that, you just have comprehensive enrollment of all tier patients. You should be able to accept all manufactured devices, follow-up of each patient for at least 1 year, complies with the relevant regulation related to protecting the human research subjects, and designed to permit ID and analysis of patients, practitioner, and facility level variables that predict the specified outcomes. The outcome metrics that they look for and monitor at this point is the stroke, TIAs, all-cause mortalities, repeat TEER or other mitral procedures, major vascular events, renal complications, functional capacity, and the quality of life. Provider's assessment, the cardiology has to fully assess the patient and review everything. And for the CT surgeon, they have to address the risk for surgical procedure, STS assessment, and clinical judgment. For functional MR, the heart failure cardiologist has also to have their own assessment, nursing evaluation for quality of life assessment, social support assessment, and as needed for other specialties too. It's very vital, it's important to have the C-suite buy-in and their support if you want to start a mitral CLEB program. I mean, to start with, you have to do your homework by looking at the geography around you, DRGs, where are those patients, how many patients, the incidence of mitral regurgitation, functional versus the degenerative, what is the hospital focus, the budget, infrastructure, and the referral pattern around your institution. You have to also realize the upfront cost, including the 3D probes, hybrid cath or OR room. You need to hire additional staff, maintaining the registries. do your homework, return of investment, downstream revenue. That's usually the C-suite, they like numbers, so obviously you have to be prepared when you present this project. Building the team, the heart team, as I said, as we mentioned earlier, the dedicated structural heart interventionist, dedicated cardiothoracic surgeon, imaging cardiologist, heart failure specialist, anesthesiologist, and valve coordinator. And if you want to look at the bigger picture with the extended team, heart team members, including the cath lab, OR, ICU, CC unit, perfusionist, and other staff as needed, like AB cardiologist, neurologist, physical therapist, cardiac rehab, which is very important, nursing, and data abstractors. It's very important to make the patient journey simple and easy, because those patients require multiple, as the requirements at the CME's requirements, they require multiple visits, a lot of workup. It's tiring for those patients. So try to minimize the patient visit, tag team approach, family involvement and education is very important for those patients. What are the expectations, risks and benefits for the procedures? And you have to have a 24-hour access for those patients to the care team for in case they need some help. Briefly about the workup, the transthoracic and transesophageal echocardiogram. Transthoracic, it's important for mitral valve assessment, tricuspid valve and aortic assessment, LV and RV dysfunctions. The TE would focus more on the valve morphology and pathology, pre-procedure gradient, the mitral valve area, other leaflet variables, tricuspid valve morphology, and also, again, the left ventricular and right ventricular function. It's important to have left and right heart catheterization, including the pulmonary hemodynamics and also aortic valve assessment. It's the most important, as we all know, the CT mitral and the CT mitral protocol to determine the mitral valve diameters and areas, annular and leaflet calcifications, modeling for valve procedures, and we heard about it 100 times about the LVOT obstruction, neo-LVOT prediction. If you can have the 3D printing, I think it's very vital and does help with the planning. It's important to have the multidisciplinary team conference, which is either done weekly if you're busy in that institution or monthly. That should include at least the CT surgeon, structural heart interventionalist, heart failure specialist, imaging specialist, cardiac anesthesiologist, outpatient nursing and clinic, APPs, inpatient rounding team, cath lab staff, primary cardiologist, fellows, resident research teams, and so on. In the multidisciplinary documentation, it is required to document the patient wishes, what are the goals, what do they want, team assessment, including the surgery, including the CT surgery assessment, the interventional cardiologist, and the heart failure specialist in case of functional MR. The team recommendation, whether surgery, whether TEER, whether palliative treatment. Rationale behind the treatment, collaborative detailed discussions. It's important to discuss the utilization of rehabilitation services before and after the procedure, length of stay and deposition. Usually patients who are at low risk, they usually go home next day. But for high-risk patients, you have to plan for longer stays, anticipate longer stays, and plan deposition to extended care facilities or other SAR facilities. I like this slide, which is I took with permission from our coordinator, Janet Wyman. It does have a full spectrum of the patient journey from the beginning, from the referral to have the patient on board, preparing the patient for the first visit, clinic visits, and discussions, evaluations, workup, and then ending up with the procedure, discharge, and the follow-up after that. Last question I have, because I think this is a concern for multiple places, specifically surgeon, thinking that a mitral transcatheter mitral valve therapy will affect the surgical volume. And I will leave that open for discussion. I personally think it's not. Actually, I do believe with me working with the structural heart specialist, I increased my mitral valve volume big time, because a lot of those patients will have no options for the transcatheter valve therapy, so they end up back in surgery. And I think the collaboration between the cardiologist and the structural heart cardiologist and surgeons increase both volume and increase both programs, and it actually very collaborative. Thank you.